Parkinson's, that's where you have a hard time initiating movement, right? The other opposite end of that is going to be Huntington's disease. Are you guys familiar with Huntington's disease? So Huntington's disease is a disease that also involves the basal ganglia, but what happens is that you're basically wiping out the D2 pathway, and the D1 pathway just takes over. The D1 pathway, the direct pathway, initiates movement, so the person can't control that anymore, and now they're just initiating movement all over the place. And so with Huntington's disease, they call that a hyperkinetic type of neurodegenerative disorder. So they're moving a lot. Huntington's disease, extremely tragic. I've only seen one case of that when I was working in the clinicals, and this guy had advanced stage Huntington's disease. He had to get brought in by a bunch of these big type of security guards that work in the hospital, because he was just flailing all over the place uncontrollably. And we'll talk about it in more detail later, but Huntington's disease, genetic disorder. So it's different than Parkinson's. There might be some genetic components of Parkinson's, but this specifically involving a genetic mutation. We have trinucleotide repeats of the CAG nucleotides. So we'll talk about that later on this semester when we get into movement. Yes?
So Parkinson's basically has to do more with the indirect pathway, right? Because they're not
Parkinson's, yeah, basically you're wiping out the direct pathway. So in Parkinson's, you can't initiate movement as well, right? So you have a hard time initiating movement. Versus Huntington's, it's going to be the direct pathway takes over, and so you have too much movement, right? So you can't control it with the indirect pathway. All right. So that was the two major regions that are going to be there to help modulate movement. And then in the cerebral cortex, you're going to have the motor association cortex. Now that is the premotor cortex. And that's where you have kind of the planning, right? You're thinking about initiating an actual movement. So you're going to plan the movement, and then you have motor control taking place afterwards. That's going to involve areas like the basal ganglia, right? It's going to help to kind of modulate those movements. And then you're going to have your primary motor cortex, aka the precentral gyrus. And the precentral gyrus is going to be there to actually allow for the movement to take place at that point, right? And it's going to be sending tracts all the way down the cortical spinal tract. And that's going to be what allows for voluntary skeletal muscle movement. The term contralateral versus ipsilateral. What does contralateral mean? Yeah, opposite side. Ipsilateral means on the same side, right? And so if you had, if you're going to move your left arm, that's going to be taking place at the right side of the brain, right? That's going to be the right cerebral cortex, primary motor cortex. That's why if you have a stroke that's affecting these areas, you're going to have contralateral hemiparesis, meaning that half of the body is going to be paralyzed. If you have, for example, a stroke that affects the middle cerebral artery affecting these areas. Another thing to keep in mind too is that you have decussation, and the main fibers that are going to be associated with muscle movement in the cortical spinal tract, they're going to decussate at the level of the pyramids. And the pyramids are going to be this region in the the medulla. And in the medulla, you're going to see those fibers on the anterior side of the medulla where you get the decussation, where it crosses over to the contralateral side. So decussation means another term for crossing over. All right, so primary motor cortex is the precentral gyrus. That's where you have control of voluntary movement for the contralateral side. It's also good to be familiar with the homunculus. You guys heard of that term before, homunculus? So I like to think of the homunculus as being this little goblin that lives within our brain, right? It's disproportionately sized depending on the real estate that it's representing. So take note of the face, right? The face and the hands especially are going to be disproportionately represented by the real estate on the cerebral cortex. Now, why is that? Think about our hands, for example. Do you want to be able to have like nice, solid control of your dexterity? It's really important, right? It's like one of the key features of even being a human, right? Like we're, we use tools, we are really good at manipulating, fine objects. Same thing with the face. The face is really important for all sorts of things. Speech, also important for facial expressions, right? There's these numbers that get thrown around in terms of like communication, right? About 60% or so of the communication is nonverbal, right, between individuals. It's going to be facial expression, movement, things like that. So it's important to be able to see what a person looks like in terms of like their facial expression. You ever see somebody who's like smiling, but you can kind of tell that they kind of want to, maybe punch you in the nose or something, right? You can tell, even though they're smiling, you can still tell, like even if it's subconscious, you can perceive a person's facial expression and kind of get a feel of what they're thinking. So lots of real estate is going to be dedicated towards the face and the hands. Now that's for motor, right? So this is why you would get one of the symptoms of a stroke affecting especially the middle cerebral artery is going to be facial droop, right? Part of the face is going to be paralyzed. Another thing is going to be they're going to have a hard time moving their limbs. So a really quick way to see if somebody has a stroke is first see if they can smile. If they smile only on one side, you get a little nervous. Then see if they can raise their arm. If they can't raise their arm, get very nervous and get them to the hospital as quickly as possible, right? Because you can reverse the effects if you treat it early enough, right? We'll talk about strokes in more detail coming up. So the tracts, motor tracts, which is part of the pyramidal system. So remember we talked about how these tracts decussate at the level of the pyramids. So that's why this is also called the pyramidal system. So this is all part of the voluntary control, right? These tracts. And the major tracts are going to be these three over here. Anterior cortical spinal tract, the lateral cortical spinal tract, and the cortical bulbar tract. The cortical bulbar tract is going to be all the voluntary movement of your facial muscles. Okay, so it's a little bit different. These other two, however, anterior cortical spinal and lateral cortical spinal, will help to allow for movement in other parts of your body outside of your face. So we'll get into those in a second. But let's talk about the upper versus lower motor neurons, because with the motor tracts, you're going to have two major neurons involved. You're going to have neurons that come off of the central nervous system, and then they're going to eventually come off the anterior horn of the spinal cord, or the ventral horn, and then they're going to synapse with the lower motor neuron. So you have upper motor neuron, that's going to be brain and spinal cord. Lower motor neuron is everything outside of the spinal cord. Okay, so upper motor neuron, central nervous system, brain, spinal cord. Make sure you know what type of physical changes are going to happen with upper motor neuron versus lower motor neuron damage. Upper, think that everything goes up. So you're going to have hyperreflexia and you're going to have spastic paralysis. Lower motor neuron is going to be everything outside of the brain and spinal cord. And if you have damage to a lower motor neuron, everything goes down. So you have hyporeflexia and you have flaccid paralysis. You can test for this easily using a reflex hammer, right? You can also test to see if they have any fasciculations in the muscles, right? So upper motor neuron damage, really, really tragic. One of the saddest patients I saw was this sweet little old lady. She was probably like in her late 60s, really nice lady. She has to come into the hospital periodically to get Botox injections in her muscles, right? Botox is a really powerful paralyzing agent, right? It's like, it is the most toxic compound known to mankind, right? Only a little bit of it can actually kill you. But it's used, of course, to paralyze facial muscles for people who want to, treat wrinkles and things like that. But you can also use it for other indications. So for this lady, she would get these really painful contractures because she had a stroke. And so she would always be, like, all of her flexors were just constantly spasming. And she could feel all of it. So she didn't lose sensation. So she could always feel all those painful contractures. So she would have to go in there like all the time to get Botox injections to help loosen up the muscles. Heartbreaking. That was like one of the saddest cases I saw. I mean, poor lady, she's trapped in her body and she's like experiences pain all the time and has to get Botox injections in her muscles. So that's a good example of an upper motor neuron lesion, right? So stroke and spinal cord damage can cause those. All right. So in terms of cortical spinal tracts, you have the anterior and the lateral. Anterior, it's in the front, you're going to think of it as being kind of these larger type motor neuron movements. And then the lateral cortical spinal tract is going to be more precise type of movements. Okay. One thing to also keep in mind here is if you take a look at the image, you see that the majority of these are going to decussate at the pyramids and they're going to turn into the lateral cortical spinal tract. So the lateral cortical spinal tract with precise movements is going to be much more important, right? But a few of those are going to come down and they're not going to decussate at the pyramids. They're going to go all the way down, and that's going to be your anterior cortical spinal tract, and those only decussate at the level of the spinal cord. Okay, so then that's where they cross over. So lateral cortical spinal tract, you get more precise type motor movements. These are considered efferent fibers. What is the difference between afferent and efferent? What does afferent mean? Yes, yeah. So you think of A as coming in. It's like the first letter of the alphabet. It's coming in. And then efferent, think exit, right? So it's going to be exiting. So you have like, you can use those terms in arteries, right? Circulatory system. And you can also use that in neurology too. So afferent fibers are going to be what? Sensory or motor? Sensory, good. Efferent fibers are going to be motor fibers. And so you get efferent fibers that are going to be coming off the anterior or the ventral horns, right, at the spinal cord. And these guys laterally, lateral corticospinal, decussates at the pyramids. Anterior cortical spinal tract, that's going to be your large motor movements. Still, though, efferent, right, because it's exiting, it's going to be motor, voluntary movement. And for these, again, they're going to leave off of the ventral horn, and they cross over at the spinal cord. So that's one of the major differences between that and the lateral cortical spinal. Cortical bulbar tract, this is going to be your head and neck, face, right? So it's going to be your motor neurons that are associated with your cranial nerves. So for example, cranial nerve 7. Cranial nerve 7, that's the muscles of expression in your face, right? So that's going to be involved with the cortical bulbar tract. Cranial nerve 5, it's going to be mostly sensory input for your face, but also muscles of mastication for cranial nerve 5. So it does have motor function as well. So your masseter muscle, if you were to clench your jaw, you guys can all do that right now. If you clench your jaw, what you're feeling over right over here is your masseter muscle. You can also clench your jaw, and you can feel your temporalis muscle. Both of those are going to be the two major muscles of mastication, and controlled by cranial nerve 5. These are also going to be efferent. They're also going to be ventral horn, and but these ones are going to cross over at the level of the brainstem. And for cranial nerve 7, crosses at the pons. So I want you guys to pair and share. I'll give you guys 2 minutes. Make friends with the person sitting next to you, and we'll go over all these together in about 2 minutes. So let's do it. Team up.
Let's do this. You want to join us? also crosses over the spinal cord at the pons.
Is the more precise means more
Okay.
Oh, I think all of them. That's what I
I'll give you guys one more minute. All right, so what's going on over here with the anterior cortical spinal tract? What is it for? What's it for? Large motor movements. Where's it cross over? Good. Spinal cord. Where's the root? Ventral or dorsal? Ventral. Sweet. All right, lateral cortical spinal. What's the motor function? Precise motor movement. Excellent. Crosses over where? Decussation of the pyramids. Perfect. Roots? Ventral. Excellent. Cortical bulbar. What's the function? Head, neck, face. Great. What about crossing over? Brainstem, cranial nerve 7 is going to be at the level of the pons.
Okay,
and
so
then
it's
just 7.
Okay.
Yeah, and then the roots? Ventral. Good. Excellent. Good job, guys. Did you need me to leave that up there? Yeah, for a second. If you want to take a photograph of that. Cool. All right, let's move on. Temporal lobe. So temporal, this is where you have processing, especially of auditory information. So think about it as being right next to the ears, right? So that's a good way for you to remember that's associated with auditory information. So it's going to have the primary auditory complex, but it can also be used for other things too. So like language, right? Memory, even facial recognition can be processed by the temporal lobe. Perception, all of that stuff. Then your parietal lobe, which we already touched on already, sensory processing. That's going to be one of the most important features of the parietal lobe is going to be sensory perception, sensory integration, processing of sensation. So touch, pain, temperature, all that stuff. Taste, hearing, smell, special senses. We're going to talk about special senses later on this semester. So sight, hearing, all that stuff. That's all going to be processed eventually by parietal lobe. So cognition, spatial awareness, things like that, that's all part of the parietal lobe. And again, here's your homunculus. Now, one way that you can test to see if a person has any sort of damage with the parietal lobe, or maybe even part of the spinothalamic tracts, is you can do the 2-point discrimination test. So the way that you do this test is you get 2 needles or you can even use toothpicks. So I think next time we meet up, I want to maybe do some especially when we do like the cranial nerve tests, we'll do some like physical exam type procedures. But the 2-point discrimination test is where you take 2 needles, you have the person close their eyes, right? And then you ask them, am I poking you with 1 or 2 needles, right? And so on the hands, especially, you should really be able to determine if it's two needles, even if they're pretty close together. Same thing with the face too. You have like lots of sensation in the face. But notice on the homunculus here, the thorax, the lower limbs, you're good. The lower limbs aren't as represented by the somatosensory cortex. And so if you were to do the 2-point discrimination test on the back, you're going to have a really hard time determining whether or not it's 1 versus 2 needles poking you. So, you could maybe try this test out with your friends after class today and poke them with toothpicks and see if they can tell you if it's 1 or 2 toothpicks. If they're trying not to draw blood, be careful about it. But if you did have damage to any of these areas, you would probably have a harder time determining whether it's 2 versus 1. I have a neurological reflex hammer, and when you unscrew this it's got like a little needle at the very top, and you can use that needle in combination with something else to do that type of test. I'm going to bring that in, I think, on Thursday, so you guys can play around with that. So, moving on. So you're going to have a couple different areas in the parietal lobe. You're going to have the primary somatosensory cortex, aka post-central gyrus, right? Because it sits behind the central sulcus. You're going to have the somatosensory association area. Then you're going to have also an area that allows you to taste, so the primary gustatory cortex. So that's where you get information coming in, it gets received, it gets integrated, and then eventually it gets processed so that you understand exactly what type of sensation it is that you're experiencing. So, post-central gyrus. This is also going to be receiving input from the contralateral side. So it's very similar to the cortical spinal tracts, right, where it's contralateral. Same thing with sensation. It's going to be coming into from the opposite side of the body. Proprioception is also going to be taking place partly here. Proprioception is going to be also taking place in the cerebellum too. What is proprioception? Yeah, it's like where your appendages are in three-dimensional space. If a person had issues with proprioception, they wouldn't know where their appendages were. So here's one test that you could do. You can have a person close their eyes. You can have them put their hands out like this. So you're going to have their hands supinated, pointing towards the ceiling. That's what supine is. And you're going to have them close their eyes. Sometimes you can have them sit down and do this test because they might fall over if they have damage to like the cerebellum or the primary somatosensory cortex. So you have them close their eyes, and if they start doing this, or their hand starts drifting off to the lateral side, and it starts pronating, which means it's pointing down, that's called pronator drift. And pronator drift could indicate that there might be damage to a portion of the somatosensory cortex, or it could also indicate damage as well to the cerebellum, right? So that's proprioception, very important aspect of your awareness of your appendages in three-dimensional space. And on that note, I think we can call it a day.